all had a little look at QI Central, given that you called in for this webinar. We really are keen to share very widely very local improvement initiatives related to paediatrics and child health. And we'd really encourage you and your colleagues to submit your work. We're trying to make it as easy as possible. For those of you who are familiar with Meds IQ, are familiar perhaps with the template, which is very much in line with the steps of an improvement project, but also with submissions for other conferences, abstract submissions. So it's to try and make it as easy as possible to share the learning more widely. And we are sort of still working on our review process, but essentially the projects do go through at least 2 people to review the submission, check that it's an improvement initiative that is relevant and has all the information that someone would require. And the idea very much is the practical aspects of it, so that other people can be inspired to take on that work locally and obviously adapt it for their local context, but have ideas, have sort of pointers towards data collection to show improvement, and actually hopefully inspire people to make other improvements to their service locally. So I don't know if any of you want to share any of your thoughts or reflections or experience you have from looking at QI Central.
So this is Mathew. This is Mathew Mathai from Bradford. So I think I really valued the opportunity to share what we're doing in Bradford on the quality improvement site. I think there's lots of great work going on around the country, and in fact, before I knew about the QI site, we were hoping to develop something locally in Bradford to share some of the ambulatory care innovation going on in Yorkshire and also nationally. It just happened that I was doing a QI project with the Royal College with regards to diabetes, and Megan Peng from the college mentioned that Cassia and team were developing a central Royal College sponsored site, where innovation could be shared. So I think it's a fantastic idea and a great place where people can just sort of throw ideas and also can develop their ideas with other centres. So I thought it was a great idea, actually.
That's great. And Leslie, have you managed to share any of your work from SAFE? So Leslie and I worked together on the Royal College SAFE Collaboratives, one of the other initiatives implementing mostly safety huddles, but other tools to improve situation awareness.
I've not done it yet. Cassie has emailed me about it, so I'll be putting on the situational awareness rounds that we did, the huddle script that we used, and also a huddle that we've developed between the maternity and the teams as well. Fantastic,
thank you. And I don't know if Joe, if you want to write anything, any comments which I can read out. Anyone else, any thoughts, anything you want to add about this, Alice and Kasia?
Well, just that we're really kind of excited about getting it going, because we managed to get so much onto Meds IQ, and it's really exciting to have that broader opportunity to share things. I think as we've always said with Meds IQ, the website is as useful as it is used. And so it's really important that everybody just continues to spread the word to get more content uploaded, so that people continue to think of it as the place to go to share their projects.
Yeah, I'd agree with that. And actually, recently we have ensured that you can upload files. So hopefully, if you have produced a poster of your work already either at the RCPCH conference or perhaps at the International Forum for Quality and Safety, if anyone's ever presented their work even locally and have a poster or any other resources they want to upload, so any of their files with sort of data or leaflets or work throughout the project, there is the option to do that as well, which I'm hoping will encourage people to upload and share their work, and be able to sort of, encourage your trainees. It's a place where they can effectively publish what they've done and share that learning. So yes, so please spread the word amongst your networks. If you use Twitter, please tweet about it.
Yep.
And I'm delighted that we've got Reena and Mathew to present one of the projects here. So I'm happy to hand over to you now, unless anyone else wanted to add anything on that. Okay, so Mathew and Reena, would you like to present your work, please? Thank you.
Great. So I just wanted to check just before we start how we progress the slides. So we've got a copy, but I'm not sure whether sort of when we progress our slides, whether you'll be seeing the slide progression.
Do you want to try?
So
Yeah.
Matt, I'm happy to move the slides as you go along, because I think that's what I agreed with Reena, if that's okay with you.
Right. Okay. That's fine. That's fine. So, so first of all, thank you for giving us the opportunity to tell you about the Ambulatory Care Experience ACE service for children and young people running in Bradford. Bradford, as you may know, has the youngest and fastest growing population outside of London. I am the clinical lead for the project, and Reena is one of our specialist trainees, ST4, who's working with us this year as a Health Education England Leadership Fellow, really to help us develop this service, but also other ambulatory care initiatives across West Yorkshire. So in the next few minutes, next slide please. In the next few minutes, what I wanted to do really was to go through the ACE service in the context of urgent care.
Sorry, Matt, can I just stop you for 1 second, because the slides are not moving for some reason.
Okay.
Really, really sorry. I don't know what happened. My
no worries.
Screen just froze. So sorry.
No worries.
Oh, interesting.
Have you got the slides in front of you, Mathew? Do you want to?
Yeah, we do. Should we try?
Yeah, if you keep talking through that, and then obviously if you need to pause, then carry on, and we can hear a bit more about it while Kash is sorting out the slides.
Okay. So what I want to do over the next few minutes really is go through our ACE service in the context of urgent care nationally, and then talk a little bit about the ACE intervention, a little bit about our ACE outcomes and the impact that we are having locally. We wanted to talk through a family perspective and show a short video clip, if that was possible, with the technology. And then some initial sort of conclusions and sort of next steps in the project. And then if people would like to find out more about what we're doing, we'd be delighted to have further discussions out with this meeting as well. So I just want to put ACE in the context of urgent care. So in the last 10 years, there's been a 30% increase in the under 5-year-olds coming to A&E. And amongst all children and young people, there's been a 15% increase in that time. Of those people coming into hospitals, around 45% need a period of observation, usually from anywhere between 1 hour and 12 hours. And only 10% of those coming into hospitals need a longer period of observation and management, lasting more than 24 hours. For us, that meant that around 90% of children coming into hospitals currently could be potentially managed in a different environment. And what's really important in the health economy, and it's quite often in the media, is that actually hospital care is extremely expensive. And in Bradford, there's about a 10-fold increase in the cost of looking after a child in hospital compared to at home. So there are a number of good children's ambulatory care services around the country that are delivering great care to their local populations. And our local team visited a number of these. And we also looked at research and evaluations of ambulatory care around the country. And what we found was that there was very little evidence out there of benefit of any of these new models. Yes, there was some published outcomes, but not much in the way of robust research evidence comparing different care models. And therefore, together with our colleagues in commissioning, as well as with families, with our A&E colleagues and in pediatrics, we really wanted to develop a solution that could be studied and, as this was a national problem, could be replicated. We wanted to be a 21st century healthcare model embodying patient-centered care. We wanted to reduce waste in the system, increase value. We wanted the service to be equitable. We wanted to focus on systems. We wanted to operate through a network, not just be the only site doing this sort of work. We wanted our service to be driven by knowledge. We wanted to have low carbon usage. And we wanted to meet the challenges by transforming services rather than just doing things more quickly or efficiently. And we wanted to focus on the family, and we wanted to work on preventing illness and education and health promotion. And what we came up with was a solution that was aiming to really address a number of points in the acute care pathway for children that was in Bradford, but also common to lots of different services around the country. So we wanted to provide a solution really that was an alternative place of observation for children and young people who were not unwell enough to require hospital admission, but not well enough to go home without support. In effect, to have an alternative to onward referral for GPs, for A&E, and for pediatrics.
And actually, Kazu, if you're able to, slides 5 and 6 show this pathway. I don't know if you're able to get onto those slides.
Oh, hang on. I think they just started working. Sorry about that. Is this the slide? Is this the slide?
So the one after that shows our current pathways. So just the next one, please. Yeah, perfect. Thank you.
Okay.
Yeah. So if you can see, can everyone see this slide with the red diamond in the middle? In primary care diagnosis. Can you see that slide? Yeah.
Yeah.
So just briefly working through this slide. So the top left rectangular boxes. So most children we know are looked after really well by their families, their carers at home. And most acute illness doesn't go anywhere near a health professional. But a number of families take their children to primary care. And a doctor makes a diagnosis, or a nurse practitioner quite often makes a diagnosis. And then the GP has only, or the A&P has only two options. One option is to send the child home with advice, and the other option is to refer on to hospital, to either A&E, a children's assessment unit, or to a pediatric. And similarly in A&E doctors have only two options: to send home or to refer the child onward. And in pediatrics, again, two options: to discharge a child or to admit them to the hospital. So we felt that actually we could potentially attack the acute care pathway at different levels and give another option. And the option that we came up with was the following slide, if you can put that on. And just click again once more. Yeah, so what we felt that if we could train band 6 nurses, we chose band 6 nurses as senior children's nurses, to deliver on specific pathways of care, that children who were not well enough just to be discharged home with advice, but not unwell enough to require onward progression through the current acute care pathway, we could send them home and have their ongoing care managed at home by trained, skilled children's nurses. And that was really the crux of our new sort of transformation, really. So there were a number of things that we did to try and mitigate the risk and to provide quality care. So we'll discuss that in the next few slides. But essentially how this new process works is that every child referred from primary care, A&E, or the pediatric assessment unit are referred according to strict pathway guidelines, according to that specific pathway. And every child gets called by our nurses within 2 hours of referral into the service. And then the nurse arranges a home visit for all patients referred into the service. Every child referred comes under the responsibility of the consultant on call in the children's assessment unit. The nurses look after a child for up to 3 days for the majority of our pathways and up to 5 days from some of our more complicated pathways. And the service runs from 9 a.m. in the morning to 9 p.m. at night, 7 days a week. And out with those times, children and families have open access to come into the hospital. And as part of our safety bundle, care bundle, we explicitly tell parents exactly what symptoms and signs to look out for to know when to escalate their concerns and how they do that. And we'll go on to that in a few minutes. So the next slide, please. So Reena is now going to just go through a typical case that we deal with, just to get you a feel for the processes. And hopefully, Kathy, actually, if you just go back without any of that text, and we'll put those lines in as Reena's recounting the story. So yeah. So what we'll do is Reena's going to just narrate a short piece, and then she's going to break, and then we'll put up just what that represents in terms of quality of care for this typical child.
Sure.
So, George's story. So my son George is 4. He has asthma. He was Chester yesterday, so I took him to his GP, expecting a referral to hospital. This time, the GP had a look at George and told me about the ACE service. She said George would be looked after at home with the help of a children's nurse.
So first point. So this is specialist children's nursing care delivered at home.
George would still be able to go to the hospital if he got any worse and at any time if he needed to. The doctor gave George 10 puffs of his blue inhaler, not a nebulizer as he normally has, before sending him home.
So next point. And the next point. So this was a model trying to integrate primary and secondary care services. And also every family is given standardized safety netting advice on what to do if their child deteriorates.
The nurse, as the doctor had promised, rang me within 2 hours, and she came to see George an hour later.
So next point. Yeah, all our pathways are initiated and delivered according to a time frame to ensure safety.
When the nurse came, she asked me some questions, examined George, and checked on his inhalers.
So next point. So as mentioned previously, every pathway has a care bundle, and there's a real emphasis on the care bundles for health, education, and promotion.
It seemed I wasn't using his inhaler right, and the spacer was too small. The nurse showed me how to use the inhaler properly and left a bigger spacer with us. She also told me how important the brown inhaler was. She wrote out how many puffs of his inhaler he should have and when. I got a call at 8 p.m. last night, and this really put my mind at rest. Thankfully, George was much better last night.
So the next 2 points, please. So all our children have regular contact with specialists and that's with the Band 6 nurse, and the Band 6 nurse communicates at least 3 times a day with the consultant paediatrician who is on call. And the discussions are based around an S-bar way of communicating, so there's no waffle. There's very sort of focused discussions which last, you know, just a few minutes. And a lot of what the nurses, you know, do is providing reassurance that actually families are managing their children appropriately at home with the right advice. And one of the key parts of the project is really to empower families to feel confident that they can manage their child's illness appropriately at home with that additional support that the nurse is providing. Yeah. So next slide, please. Okay. So we just wanted to highlight some of the key features of the service, which hopefully will spark some discussion after our presentation. So we believe ACE is the first service of its kind in the UK to have clinical pathways covering community and secondary care services that standardise referrals and community management, that empowers families to self-manage at home and promotes nurse-led discharge. In addition, as mentioned, consultant paediatricians take clinical responsibility for all patients in the service from the point of referral. ACE was implemented in 8 months from the decision to commission to the delivery of the service. ACE was developed within a robust clinical governance framework that has been tried and tested over the last 16 months. And although ACE was commissioned to reduce hospital avoidance, the clinical pathways can clearly be used to reduce inpatient length of stay.
So moving on to the next slide, please, Kazia. So the problem we face in Bradford isn't unique. So we therefore developed ACE to be easily adapted and used by other acute systems, and hence it's a standardised intervention. It has a simple design and we've packaged it for spread. The service, the models and the pathways can be used off the shelf, and the packages include a number of different documents which you can see on the screen. We wanted to highlight one document in particular which George from our story benefited from, which Kazia is on the next slide. And this is the care bundle for wheeze. The wheeze pathway ensures that we provide a consistent and high quality care 100% of the time, and each of our pathways has a specific care bundle. So moving on to training. So ACE is delivered by Band 6 nurses and not nurse practitioners. A bespoke training package was developed with our doctors, nurse practitioners and nurse educators. Our nurses were trained over a 3-month period and taught generic and pathway-specific skills. They're required to pass a set number of clinical examinations and case-based discussions for each pathway, and to pass an OSCE-style assessment. We feel our ACE nurses have really improved workforce integration between our medical, nursing and nurse practitioner teams, and they feel that they're making a real difference to its success. We've even been able to attract and recruit nurses from outside our trust and from outside our region. Earlier this month, we met with the Yorkshire and Humber Postgraduate Dean at Health Education England as well to develop a training module to deliver ACE in other trusts. This module, we hope, will be the first ambulatory care course of its kind in the country to train nurses to deliver a specific service. So if we move on to the next slide. So just a bit about collaboration and spread here. So we've been working with families and the MDT team from across the healthcare system from the very beginning, wanting to collaborate with others and to be outward facing. We've used our webpage and social media to keep in touch with families and with other professionals. We've linked in with our local integrated care system, who see ACE as a service that all trusts should aspire to, and they hope to replicate it across the other 5 acute trusts in West Yorkshire. There is also interest in neighbouring sites for the replication. One of my roles this year is to bring together stakeholders from across West Yorkshire to co-innovate in this exciting new area. We're also really keen to be involved in the development so that other teams can learn from our successes and the challenges we faced, which is why it's a great opportunity to have our work on the QI Hub. We're also hoping to feed into the RCPCH 2040 project, which, as we all know, is studying new models of paediatric care in order to meet the needs of children and young people over the next 20 years. We're also hoping to use telemedicine to help us move into more complex clinical pathways, including children with complex needs and on palliative care plans. And we're hoping to develop links with other partner agencies, for example, the Yorkshire Ambulance Service, to see if we can streamline our common acute pathways. Our collaborative efforts have also been recognised by the King's Fund, who invited us to do a blog post for them recently. So moving on to research now. Unfortunately, there's very little quantitative research in ambulatory care, making commissioning decisions incredibly difficult. It's also meant that many ambulatory services, as we know, have been decommissioned. York University are conducting an external academic evaluation of our ACE service using linked primary and secondary care data to follow the patient journey. And this is sponsored by the Academic Health Science Network's Connected Health Cities project. We're also hoping to work with Netamis, a Leeds University-based software company, using novel techniques to model services by simulating patient flow to identify bottlenecks and assess costs. We've also linked in with other research teams, including Peruki and the National Institute for Health Research for specific sub-projects. Now, clearly, none of this would have been possible without visionary commissioning, which Mathew is going to go on to tell you about now.
Okay, so next slide, please. So ACE is the result of relationships developed over several years between our commissioners and paediatric clinical team. I've been a consultant here in Bradford for 11 years now, and we started 11 years ago looking at how we could co-locate our assessment unit and paediatric A&E, and we're still sort of working through some of the implications of that. We haven't managed it so far because of sort of infrastructural issues. We developed some pathways that were shared across the system, but unfortunately there was very little buy-in. So we've been sort of thinking through system-wide working for quite a long time, but the local need for a service like ACE was clear, and it became clearer over the last few years. It also fit with the overall CCG strategy of happy, healthy home. It was clear that paediatrics had been missed from most national policy documents. So we set up a children's-focused urgent care work stream, and the commissioners managed to free up some transformation money for the pilot. So ACE's success has meant that we are now looking at widening the ACE service to neighbouring trusts. And with the support of our integrated care system, are delighted that another trust locally is looking at full replication. The next slide, please. So as a clinical lead and the project board, we were tasked to deliver on 5 key performance indicators. And the team have met 4 out of the 5, but at present we have not achieved the minimum of 6 contacts per day, and this may come out in the discussions a bit later on. Next slide, please. So the service so far has received referrals from 47 different GP surgeries, which is just over 70% of the GP surgeries in Bradford. And primary care referrals currently make up around 50% of GP referrals, but 62% of primary care referrals in total. The service to the end of March received 410 referrals, 358 were accepted, 52 didn't meet the referral criteria, 344 were seen by the ACE team, and 14 were diverted to the hospital as they were referred out of service hours. This meant that 284 remained at home, and this equates to 83% of assessed referrals remaining at home. The service, we believe, has saved approximately 391 bed days, and I'm really pleased to say that there's been no adverse events in the last 16 months. Next slide, please. So importantly, what do our families think? I hope that this film does play and you get a feel for what our families think about the service.
Can everybody see it?
Yes.
Yes?
The slide. I can't see it.
Not the video, not the video, no.
Sorry, hang on. Can you see it now?
Yeah.
Oh, yeah.
Yes.
Yes.
You have this service where the nurse comes out to your house and helps you monitor and manage your child's condition. But I was relieved in the sense that my husband was away. I have an 11-year-old. It would have been hugely difficult if he was admitted in hospital. So to have somebody at home in a setting where my son wasn't nervous, I wasn't nervous, it was fantastic. It absolutely gave me peace of mind to have acquired that knowledge from the nurse and then the medical team. So much so that recently Yahya had a similar episode where his breathing was deteriorating quite rapidly, and I just followed the same routine what the nurse said and imparted. And so it was fantastic. I didn't have to call an ambulance down. When Mathew had said that they haven't got this sort of service throughout the whole of the country, it was a bit of a shock. They should have. Many children often thrive in the hospital setting, and to have them at home, I'm not comfortable. Originally, my son, he was so afraid of using the inhaler and the chain. Now, he doesn't associate it with any medical experience, home experience. I think that's the most important thing. It was a worthwhile experience, let's say, and it stayed with me for a very long time.
So thank you. So I think one of the key things, which I'm not sure whether you heard in that video, was this this mum essentially was her child was looked after during quite a stressful time for the family at home, and the whole care became a home experience rather than a sort of a hospital or health care sort of experience. It was a home experience.
Oh, sorry.
Okay. But I think one of the key things to me in what she said, which I'm not sure whether I didn't hear it very well on the video, was that this actually prevented another hospital call out. So she said that actually a few months later, her son had another exacerbation of asthma, and she was going to call 999, but she used the information and the advice and the education around asthma that she was given on the previous clinical review at home by the ACE nurse to prevent a 999 call out. And to me, that sort of is a really sort of important part of what we're trying to do. We're trying to empower families to manage common illness at home and to access help when they really need it.
So next slide, please. So what are we planning over the next year? So one of my roles as the Leadership Fellow is to try and develop a West Yorkshire clinical network in paediatric urgent ambulatory care as a platform where we can share ideas. We're hoping to increase child and family engagement in further development of pathways and hoping to implement engagement strategies with referrers as well. And finally, I mentioned education earlier, and we're hoping to develop a university module which is actually supported by Health Education England. So in conclusion, just for our final slide, we believe that we're innovating for the future. We're providing quality, patient-centred healthcare that is really delivered at the right time and in the right place for patients. We've enabled better system integration with a skilled workforce. and we're aiming to be research driven and collaborating with other stakeholders. We really want to empower families to access healthcare appropriately by providing consistent health education and promotion. And we really believe that ACE is a new care model for the NHS. Thank you. I think our last slide just gives you a link to our webpage and also further patient feedback. So thanks for listening. Any questions?
Thank you so much. That was a brilliant presentation. I certainly have a couple of questions, but does anyone else want to start?
Perfect.
Okay. Sorry, and I've just seen we've been joined by Kumar Prashant at City Hospital's Sunderland, consultant paediatrician. Welcome. He's joined on the chat at the bottom. Yeah, I thought it was fantastic, and you covered quite a lot of my my initial kind of thoughts about training of the nurses, which I think, you know, sounds like that was probably quite a large piece of work in itself, actually. And a little bit about clinical governance. So, as you said, the consultant is responsible from the point of referral. Can you say a bit more about your clinical governance? Because obviously although it's a totally the right strategy for keeping children out of hospital, clearly it's always something that worries people in terms of risk and governance. Yeah,
so when we developed the project, we clearly wanted to do it safely. And so all our pathways had sort of multi-professional sort of input in developing, and we were based on what was national guidance and also local discussions with GPs, nurse practitioners, nurses. So we wanted the pathways to start off, you know, having as much evidence base, but as you know, there isn't a lot of evidence base around ambulatory care. So we were extrapolating from things like the BTS sort of guidelines on management of asthma, gastroenteritis. There's no nice guidelines on croup management, but there is some advice on how we should go about managing croup. We're doing home oxygen for children with bronchiolitis and also neonatal jaundice, where there isn't much guidance out there, and it's sort of it's based on, you know, discussions with clinical colleagues and other teams that have already started doing this sort of work. So in terms of the pathways, the governance and the background was, you know, as much evidence base as we can, but also working with colleagues around the country who are doing similar sort of work. In terms of the processes of the service, so again, very much multi-professional, and we had a work stream for the project just looking at governance issues, and so we had issues around sort of how the inpatient and the community nurses would work, and how that interaction was really important. So one of the key things was that as part of our key performance indicators, nurses in working in the community had to have 100% access to consultant paediatricians when required. We had set days, we had set times during the day when the nurses could communicate with the consultant, so that consultants could have some sort of idea when they were expecting a call, but also in between, if a child was deteriorating, that the nurse could also contact us. So there's an escalation policy. We had a policy around safeguarding, so if there's any safeguarding issues picked up by our nurses, how that would be escalated. We also had issues around weather conditions, or whether, you know, we couldn't provide a service and what happened then. We also had sort of mitigation for when we couldn't contact the family once a child was referred, and also what happened then. We have patient information, which outlines the responsibilities of the family, the responsibilities of the referrer, and the responsibilities of the inpatient team as well. And those are just some of the governance type things that we've put in place. And as I said, you know, so far those governance processes have been tried and tested for the last 16 months without any significant adverse events. and we continue to review what we're doing. Should I go on to training, or do you want me to ask me any questions on that bit?
No, that was great. So your local departmental governance or risk lead would then take responsibility, I guess, for any of the for looking at incidents and reviewing anything that could, if anything does come up.
Absolutely. So all these documents, our processes, were discussed in our local sort of guidelines meetings, our local governance meetings, and they're all being signed off. They're on our intranet and are open to access to our referrers as well as the clinical team in the hospital. So we're very transparent, and that's why we wanted to be transparent for many reasons, not least the fact that if other services was looking to replicate, they would know exactly how we function.
Yeah, that's great. And presumably you have strict criteria as to who's accepted. You talked about certain pathways. Do you have a sort of
yeah,
a kind of inclusion kind of list?
Absolutely. So one of the things we were really clear about at the start of this was that we didn't want to make another service that actually where children would be referred where they wouldn't be referred ordinarily. So we didn't want to have children that the GP or A&E or pediatrics would just send home with some advice. We wanted this to be an alternative next step to those referrers. And therefore, all our, we refer to them as referral crib sheets, have the inclusion criteria. And the inclusion criteria includes physiological parameters, which the referrer has to do. So our GPs, for example, or GP ANPs, need to take, for example, for asthma, need to take, heart rate, respiratory rate, saturation, temperature. And not only that, they have to also initiate treatment. So for asthma, we only accept children who have been given between 600 and 1,000 mics of salbutamol in the practice. So if they're a child who's not that unwell, who maybe only requires maybe 100 to 200 micrograms of salbutamol, they're not unwell enough to be referred into the service. And all the pathways are based on that sort of model. So they have to meet certain criteria. So they can't be well children or just in case child. They're sick children who actually need to be managed and who ordinarily would have been referred on to either hospital or to the pediatric unit, but now can be looked after at home. And the referrer has to do a number of things before they can refer. And that was really to be a gateway so that we don't get patients that ordinarily wouldn't have come to us.
Yeah, I mean, I guess that, sorry, I was saying, I guess that involves a lot of engagement of the GPs, and you hinted that you already had some quite good networks, but how did you get everyone on board with this? Because it was over 70% of the practices, which is impressive. Yeah,
so we, I mean, this has been a project that has been driven both by secondary care, but also by primary care. And it's just, the project was developed at the right time because the commissioner who's lead for urgent care is also a GP who also works with us as a junior doctor, so knows how we work in the hospital. He knows how things work in primary care, but he's also a commissioner, so he's sort of seen it from lots of different angles. So he's done quite a lot of engagement in primary care, but we've also gone out into primary care, and our nurses have been allocated to what are called primary care hubs in the city. So in Bradford, we have a north, central and south primary care hub, and nurses are basically attached to these different hubs, and they're the face of ACE in their GP surgeries. So if we have any new pathways, or if GPs want to know more about the service, those nurses are known to those practices, and they go and promote the service. We've also done larger forum meetings and presented to large commissioning groups, and we use Twitter and Facebook as well to try and keep in touch with some of our practices as well. As you may remember from the presentation, we're not hitting our capacity at the moment that we wanted to hit. And we have developed an engagement strategy of how we hope to increase the number of referrers in. One of the big things that I think we need to develop is our patient and family and child engagement. And I think really, you know, we haven't had one negative comment back from our patient and family and child questionnaires. And I think our children and families are going to be the key driver for further development. On our webpage, we have posters that we've encouraged GP surgeries to put up in their surgery, advertising the service. And we would like families to look at those posters and say to their GP, oh, actually, you know, I think, you know, does my child fit that category to be looked after by the ACE team? So we're trying lots of different ways. We want to use GP registrars to be champions in their practices. We want to do some more work around A&E referrals, and obviously in pediatrics as well, getting our juniors to engage with this new form of working as well.
That's great, thank you. Does anyone else have any questions?
Yes.
Yes, hi. Oh, God.
Sorry. All right. Hi, I'm Samaya, a pediatric pharmacist from Medway Hospital. I just wanted to check whether there was any pharmacy involvement, and especially with issues regarding, you know, medication supply and storage, especially
that's a great question, and I'm pleased to have had a pharmacist. So our senior pediatric pharmacist has been involved really over several years, but over the last couple of years as we've developed the service, Manrita Katkar has been a really sort of central person in this. Because as you can imagine, what we prescribe in hospitals is sometimes different to what is prescribed in the community. And that particularly arose with the croup pathway, where in hospital we give dexamethasone as our first line, but issues of you know, dispensing that in primary care. So she has worked with sort of primary care and you know, how we can sort of, you know, get around that, and what sort of drugs are appropriate to prescribe and how they're accessed in A&E and in pediatrics. On the RCPCHQI webpage, we've got a list of stakeholders who are involved in this project, and Manrita, I'm sure her name's there, and I'm sure she'd be happy to speak to you about pharmacy issues.
Okay, all right, thank you.
Thank you. Any other questions?
Yeah, hi, it's Alice Ruchet. Thank you so much. That was really, really fascinating. We have a hospital at home service in our trust, but I really liked how you've managed to get the primary care engagement so kind of fundamental to it. Yeah. I had a couple of questions. One was, you mentioned that your aim is your target is to try and get 6 referrals a day, if that's right. What's your capacity? What's the maximum you could manage? Yeah,
a really good question. I mean, I think because this was a pilot, and it's still actually classed as a pilot study, and when we started this, we had nothing. So we started with 0 governance documents, pathways, etc. So we started really from scratch. So for the first 6 months of the project, we only had 1 pathway in, which was the wheezy or child with asthma, and we didn't really know how popular, you know, that would be. And the commissioners, because they got the money from transformation money, you know, we looked at how much money that, you know, that was, and for the money that was available, we could get 2.52 whole-time equivalent nurses to run the project. Now, different to probably other trusts around the country, our community nurses actually sit under the acute trust. They don't belong to the district trust or you know, other trusts. So we have some ability to flex up and down our community nurses. And we got 3 of our community nurses who weren't actually assigned to the project to also be trained up in the pathways that we were using. So we had 2.52 whole-time equivalents plus 3 community nurses who weren't commissioned for the service, providing resilience. Now, it so happens that 2 of our nurses, one nurse went into nurse practitioner training, and another nurse happily went into maternity for maternity leave. So we've really struggled with our nursing nurses, and that's one of the reasons why we didn't implement all our pathways in one go. And we have got sort of home oxygen for broncholytic babies and home phototherapy for jaundice babies imminently going to go live. But because of staffing issues, we've held back a little bit. but we hope to go live. Now, for a new service looking at all of these pathways, which we've developed and trained our nurses, what we're hoping to have is, we've got five pathways ready, potentially working. And when we talked to Health Education England and the postgraduate dean a couple of weeks ago, we felt that we could potentially deliver training over a 3-month course to deliver sort of generic training, but also pathway-specific training. So the pathways have been a concern. I think the capacity, when we said we wanted 6 to 10 contacts a day, that wasn't 6 new referrals a day. It was actually 6 contacts, like phone calls or home visits for patients maybe who are already on the list. But it could mean on some days, on some busy days, we have maybe 5 or 6 referrals. On less busy days, we don't have any at the moment. But that's also because we haven't got all the pathways up and running as yet.
Okay. Thank you. That's really, it's really interesting. I'm really intrigued about, or pleased that you're going online with the oxygen at home for bronchiolitis. But I can see that might require a little bit more contact per patient. And are you? It looks like the kind of the focus has been on the primary care referrals. Presumably, do you also offer like sort of step down support for discharges and also admission avoidance from A&E?
Absolutely. So when we got the commissioning, it was really to reduce hospital admissions. Now, it does include A&E assessments, so we don't consider it step down when they're referred from A&E or the paediatric assessment unit. Once they hit the observation unit, we look after children for up to 24 hours in our observation unit, or if they hit our inpatient beds, then they're considered step down if we discharge them early. Now, essentially, we are trying to develop one team which does both step up as well as step down, because the skills are obviously very, they cross both areas. And we already have an ambulatory antibiotic sort of pathway for our patients, but we really want to look at some of the other things, like, for example, newly diagnosed children with diabetes, children with nephrotic syndrome. In Bradford, we've also got a large number of children with complex needs, and looking at whether we could manage them better at home. And also, we've got quite a large number of children on palliative care or end-of-life plans. We don't have a hospice in Bradford, a children's hospice, but there's a hospice around 1.5 hours away from where we are. We felt that actually, with potentially use of new technology like telemedicine, we could actually improve communication between families, their primary hospice carers, and also the hospital. And looking at more sort of complex pathways like that, with the use of new and emerging tech as well, is something on our radar and something that we're keen to develop.
Wow, fantastic. Well, I feel like I could keep asking questions indefinitely, but actually I'm aware that it's 2 minutes to 2. But thank you so much. That has been really sort of interesting and inspirational. I love that you've packaged it for spread. So it would be really interesting to think about how one if it does spread and you have other sites using it, how you then bring everyone together and say, well, what are our different experiences using this? But thank you so much.
Yeah, and we'll be at the Royal College meeting as well. We've got a poster, so if anyone would like to come and have a chat with us, very happy to link in and collaborate and co-innovate really in this area.
Brilliant. Well, I'll see you there.
Yeah,
brilliant. Well, thank you so much. And just to finish off, as Alice said, in the last couple of minutes, I'm glad you mentioned the Royal College meeting, because that was going to be something that we want to share with you all, that there are quality improvement sessions again this year in the programme. Please have a look in the programme for those. There's, I believe the session's running on most days to do with QI. Is that right, Kasia? Do you want to say a little bit more on that?
Yes, we have our flagship QI symposium on the Monday, which starts at 11:45 and runs through to 4 o'clock with a break for lunch. In this session, we will present, or actually the authors will present the top scoring QI abstracts submitted to the conference. And we will also have a keynote speaker, Dr. Johnny Tate from Australia, from the Quality Care Commission, as well as speakers presenting on the RCPCH Diabetes Quality Program and the SAFE program, which is now being rolled out in Ireland. So we're going to have a speaker from the Royal College of Physicians in Dublin talking about that. Then on Tuesday, we have a session on universal health provision. We will have Dr. Mathew Nielsen from WHO speaking, as well as Ingrid Wolf from the Evelina Children's Hospital. And then on Wednesday, we have a session about engaging patients and families in quality improvement projects. So we have a very interesting program. You can also find out more about QI Central itself at our drop-in session on Monday morning at 9:30, which is going to be in the main area of the exhibition village.
Thanks, Kasia. So yes, it'd be great to catch up with you, some of you then. And in the meantime, please keep promoting QI Central in all your networks, and do upload your posters, any relevant resources. I was thinking, Mathew and Reena, we could perhaps put upload your presentation alongside your submission. That might be nice as well. So,
yeah, that'd be wonderful.
Thank you.
So any final questions, comments, anything else you wanted to add, Alice or Kasia?
No, I think that's great. But it's just really exciting seeing the breadth of things that we can start sharing through these webinars. And yes, thank you so much for the presentation.
Great. Thanks very much. Thank you.
Yes. I just wanted to apologize to everybody for the technical glitches today, and particularly to you for not showing your first few slides. It's been a bit challenging on my end, but I hope that it's worked for everybody in the end. And as Jane and Alice said, thank you so much for joining us and sharing with us your amazing project.
Thanks very much. Thank you for the opportunity.
Thanks.
Yeah, well done. Thank you. And yeah, I hope to meet you next week.
Yeah, great. All right. Bye.
Bye. Bye.